This is a note part of like the Step 2 shelf lecture series, but the biostats content that's discussed here, a lot of the formulas and experimental designs and types of biases and confounds really would be relevant for any of your USMLE exams or COMLEX exams. I tried to pick content that's really high yield wherever you are in your studies, and that's important to know as well for reading studies in everyday life and just knowing good medicine. So we'll start with knowing how good a clinical test is. So when we do these tests, we come up with screening tests or diagnostic tests for the reason that we want to either be able to pick up a case of disease and not miss anything. So like a screening test, I want to make sure that every single person who needs more evaluation I capture, or to be really, really certain that there is a certain disease. So once I've screened everybody who I need to take a closer look at, I want to be sure before I proceed with treatment or proceed with surgery or whatever I'm going to do that I'm definitely targeting the right thing. So there are two different kinds of tests, and we look at two different things to determine that. So the first one is sensitivity, and that one's how good we are at picking up cases. So if I want a test to be really sensitive, I'm worried about capturing everything that could possibly be abnormal. So if there's a chance that someone's at high risk for a condition or has a condition, I want to make sure that I don't miss a single case. So this is basically what percentage of the time will it pick up the disease if it's there. So for example, if someone has cancer, what percentage of the time will this test tell me that they have cancer? So if a highly sensitive test, it rules out the disease. So if the test is guaranteed to pick up something that's there or has a 99% chance of picking up something that's there because it's highly sensitive, that means if I do not screen positive on this test, then I'm okay. I don't have the disease. So this is great for screening. It's a test that might set a really low threshold for looking closer. So another example of this is like that newborn screen in the United States. Every baby at 24 hours, they poke them on the heel, it looks for stuff. For a lot of reasons, it can pick up a particular disease, like the level of thyroid hormone is a little low or something. That baby might not actually have that disease. It just looks for a baby that needs confirmatory testing. So it will not miss a single case. It may pick up some cases that are nothing at all, which is the next concept that we'll talk about, sensitivity, but the goal is not to miss a single case. This is great for screening, saying who does or might have this disease and I should look closer. So then there's specificity. That's how good is the test in knowing if there's no disease. So this is, if I want to test this highly specific, I need to be very, very sure if it picks up this disease that it's definitely only that. And I need to be very, very sure that if there's no disease, I'll get a negative test. So this is great for something that you're going to make a lot of decisions off of. So I need a highly specific test if I'm, say, doing a surgery for appendicitis. So I might do a highly sensitive test first. Anyone with abdominal pain, I'll screen with the CBC. Then I need something highly specific. So I need to know before I cut them open that they don't have gastroenteritis that also caused a high white count on a CBC. I need to have, say, imaging findings of the appendix, which are super specific, because I need to be absolutely positive that if there definitely is a disease, there's no way I'm giving a treatment or a surgery to someone who has no disease. So highly specific test rules in the disease is great for diagnosis. So in other words, if my test is highly specific and it comes up and says this disease is present, that's definitely the disease that is present. Definitely confirm the diagnosis. So I want to use a sensitive test that picks up everything just to screen what do I need to look closer at. I want to use a specific test to nail that diagnosis. Out of those people that I look closer at, who am I positive actually has this? These are the things that the doctor cares about, sensitivity and specificity. So when I'm picking a test to run, I want to know if I'm screening or diagnosing. These positive and negative predictive values are what the patient cares about. So think of this P and V for what the patient values. So the patient wants to know this. Positive predictive value is I have a positive test. I'm looking at that result that read positive. How sure am I that's real? So if I screen positive, say I test myself for COVID on one of those home lateral flow tests, how sure am I that if I went and I got a PCR, I really truly would be positive? So this is what the patient cares about. A test told me I have this disease. Doctor, are you sure I have this disease? And the negative predictive value, the other. I tested negative. How sure am I that this is truly negative? So I did a test that tells me that I definitely don't have cancer. Can I be absolutely 100% certain that really don't have cancer and I don't need to treat any further seek any further diagnosis or treatment. So sensitivity and specificity are what the clinicians care about. PPV and NPV are what the patients care about. So I think P for patient, predictive values for things that patients value. So those are our types of tests. Oh, okay. Someone was just asking to share the slides. I sent them to Austin. I see he put them in the chat. So these are our formulas. I like to break it down. How does the USMLE or COMLEX define it? What are those number variables if I make like my positive and negative test table with the A, B, C, and D? What numbers would I use? And then what does the test actually mean? What do I care about when I'm doing this test? So for sensitivity, it's true positives over true positives and false negatives. So basically, this is true positives over everyone that actually had the disease. So how likely am I to test positive if I have the disease? If I'm looking at my four-way table, this is A over A plus B. Specificity is true negatives over true negatives and false positives. So this is testing negative if you don't have it. Or in my table, D over C plus D. Then positive predictive value is how many people test positive or are truly positive out of people who come out positive on the test. So if I test positive, I divide that by the true positives by everyone who tests positive, whether true or false. So A over A plus C. A negative.
Yeah, I think it might have, I don't know if you mentioned it on the screen or not, or maybe it fell off. Could you draw out where A, B, C, and D are out on the table for everybody that's following along?
Oh, sure. So we'll put our test here and we'll put our condition here. And you can either test positive or test negative. And then you can either have the condition or not have the condition. So if I test positive and I have the condition, then I'm a true positive. So we'll call that A. Then here, if I test negative, but if I test positive but don't have the condition here, these guys would be my false positives. So we'll call those false positives here. If I test negative, but I actually did have the condition, then we'll call those our false negatives. And then if we test negative and don't have the disease, we'll call those our true negatives. Any questions on that? So then let's look at these questions and let's decide what should be PPV, NPV, specificity, or sensitivity. So Miguel completes a screening test for lung cancer and he screens positive. He asks the doctor, what are the chances that I actually have lung cancer? So what does Miguel care about here? Right, PPV. Good. So positive predictive value is if I screen positive, what are the chances that I actually am positive? Miguel cares about that because Miguel's the patient. So Laura is going to visit her new nephew who was born at 36 weeks in the NICU. She takes a test for RSV, which is negative. How certain can I be that I don't have RSV, she asks. So here Laura wants to make sure she doesn't go into the NICU with RSV. What value does Laura care about here? NPV, right. And then here, Mr. Sampson is designing a new test for Sanfilippo syndrome, a rare childhood disease. I don't want to miss any cases. So if Dr. Sampson doesn't want to miss any cases, what value is he caring about? Sensitivity, good. And this last one, Dr. Hubbard is performing a bone marrow aspirate in a patient to confirm a diagnosis of BSA-ALL. So here he's doing an invasive procedure. It'll require chemotherapy. So he says, I want to be certain that I diagnose leukemia and nothing else. So what does he want to maximize? Specificity, right. So this is the important thing here, the difference between sensitivity and specificity. Dr. Sampson wants to pick up everybody who could possibly have the disease. They're going to wind up getting referred to genetics. They're going to wind up doing a bunch of stuff. So it's okay if I'm highly sensitive, as long as I capture everybody. It's okay if I pick up some people that maybe didn't have it. It's just for more screening. Here, I want to confirm that it's definitely leukemia. That means this kid's going to be subjected to a bone marrow aspirate, which is surgical, and they're going to be subjected to chemotherapy. So if I'm doing this, I really want to make sure that I know that it's leukemia, that I didn't do it because the high white count was because of pneumonia or something. So it seems like we got those. Any questions on that?
I think that was a really good explanation. And one thing that I've always kept in mind that has never really steered me wrong on board exams is the more invasive, it's generally the more specific.
Yeah, I think that's good advice, because you always want to make sure if you're doing something invasive that you're doing it to be absolutely certain, and that you're absolutely certain before you move on to the next invasive step. So then we'll talk about epidemiology of population statistics. So this is basically how common diseases are and then how risk factors relate to diseases. So prevalence is just the percentage or the proportion of people with a condition at a given time. So this is like right now, how many children are obese? 1 out of 5 kids in the US are obese. It does not matter when those kids became obese. It doesn't matter if they've been obese for 15 years. It doesn't matter if they became obese yesterday. It just matters out of all of the children that exist in the United States, if I break them up 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, every 5th child will be obese. Incidence is the rate at which new cases develop over a set period of time. So this is like I have 20 children and 5 new ones developed flu. So that doesn't count the ones that already had flu. It doesn't count the ones that don't have flu. It's just 5 kids developed flu, 5 new index cases. It's usually over a period of time. So oftentimes they'll do it like new cases of lung cancer over a year, or new cases of diabetes over a 5-year period. Most commonly it's a year, but incidence will give you a set period of time. These two are really commonly confused, so I'd pay close attention here: an odds ratio and a relative risk. So an odds ratio, that has to come out of a case control study. So the way a case control study works, we'll get into this in a little while, but it is the way that it divides people by study groups is disease and no disease. So I look backwards at a risk factor. So I say I divide people by lung cancer, no lung cancer. And then I look backwards and I decide, did they smoke? Did they inhale a lot of exhaust? What risk factors did they have that led them to the group that's lung cancer or no lung cancer? So that's chances of an exposure given a certain outcome. So people with lung cancer are 5 times as likely to have smoked than those without. So if I gather up the people who have lung cancer and gather up the people who don't have lung cancer, and I look backwards, maybe 20% of them in the lung cancer group smoked, but only 4% of them in the no lung cancer group smoked. I'm looking backwards from whether they have lung cancer or not. The relative risk are the chances of having a certain outcome given an exposure. So this comes from a cohort study. So this one I'm looking forward. So this one I break them by smokers, no smokers. I don't know and I don't care whether they have lung cancer or not until I complete the study. So I gather people who smoke, I gather people who don't smoke. I follow them and I look forward and I say, if I smoke, am I more likely to get lung cancer? So this is, instead of dividing them by smokers, non-smokers, or lung cancer, non-lung cancer, this is if I look at the smokers, I look at the non-smokers, and I say 1 in 10 smokers develop lung cancer, but only 1 in 25 non-smokers develop lung cancer. So it's looking from whatever the risk factor is to whatever the disease is, instead of from whatever the disease is to whatever the risk factor is. So that's the best way to remember that. Relative risk reduction, it basically talks about whether I smoke or not, there's some risk of lung cancer. But what amount of the risk can I take away by taking away the exposure? So how much can I cut down my risk of lung cancer by not smoking? So this is the proportion of the risk reduction that happens relative to the control. So basically, if I stop smoking, I get an 80% discount on my chance of lung cancer. So I might still get lung cancer, but I have an 80% decrease in my chance of getting lung cancer if I don't smoke. And that's related to absolute risk reduction and attributable risk. So absolute risk reduction is the amount of risk reduction due to exposure. So for example, if 80% of smokers get cancer and only 5% of non-smokers, then it goes down by 75%. I just take 80% minus 5%. And then attributable risk is how much of the risk is actually attributable to this risk factor. So out of all of the people in the world who get lung cancer, whether they smoke or not, how much of that lung cancer can I blame on smoking? Some of it I can blame on bad genetics, some of it I can blame on working in construction, some of it I can blame on pneumoconiosis, whatever. How much of it can I blame on actual smoking? So I can blame 70% of lung cancer just on smoking. And then number needed to treat and number needed to harm. We use these a lot in clinical trials or drug trials to say basically how many people would I need to expose something to help someone get better, or how many people would I need to expose to something to see an adverse effect. And those numbers help us decide whether something is safe or worthwhile, because if my number needed to treat is like 10,000, but my number needed to harm is like 4, then yeah, I might be treating people with that drug, but I have a much higher risk of adverse effects. That drug might not be worthwhile. So the number needed to treat is the number of people you need to treat or give whatever the exposure or drug is to prevent or cure disease in one person. So if I give 10 people statins, I might take away 1 heart attack, for example. A number needed to harm is the number of patients who need to be exposed to a risk factor for one to develop disease. So if I tell 5 people to smoke, I might have 1 develop lung cancer because I have the 5 people smoke every day.
And that's honestly, all these numbers and terms honestly sound like bogus when you're in med school. But this is something that I actually utilize whenever I'm counseling patients in clinic. Like if I have somebody that's got carotid artery stenosis, I tell them exactly like how many people would benefit from the surgery before that there was a poor outcome, for example. And so you need to know number needed to treat, number needed to harm, and that's going to help guide you, because if you got to treat 50 people with a very invasive surgery for one person to get a beneficial outcome, you would never do that. So that's really why that this stuff starts to come into play. It seems like bogus, but I promise it's something that can be useful for you later on in your career too.
They're extremely high yield, and I think it's because it is important to talk to patients. We talk to this a lot in peds with the vaccine hesitancy. So you can tell the parents like, okay, yes, like people get Guillain-Barré from vaccines, but there your number needed to harm is like 1 in 10,000. You need to give 10,000 people the vaccine to get Guillain-Barré, but it can prevent cases of measles, and the number needed to treat is like 20. If we get below 90% herd immunity, we'll start getting measles outbreaks again. And that can be helpful for the parents to see, like, I get that you're hesitant. I'm acknowledging that, yes, there are risks, but the risk of going without is way higher. So it is definitely something that's relevant. It's something that patients like to understand. So these are formulas. Again, it sort of breaks into one of those tables with events and exposures. So this is the event or the disease. And then this is the exposure or like the risk. So we'll just stick with our example of lung cancer and smoking, since we've been using that a lot. So it breaks this into a table. Basically, yes, they have the disease, the lung cancer. No, they don't have the disease, the lung cancer. Yes, they have the exposure of the smoking. No, they don't have the exposure of the smoking. So if they have that, we'll call them A. If they don't get the lung cancer, but they did smoke, if they got very lucky, we'll call them B. If they had the lung cancer, but no exposure, we'll call them C. And then if they had neither, we'll call them D. And then we can calculate an odds ratio. This is odds in the exposed group divided by odds in the unexposed group. Relative risk is the risk of disease and exposed over disease and unexposed. So the difference here is when we do the odds in the exposed group, this is creating like an odds ratio. So like if we're betting, the odds are like 2 to 1 win to loss. So we include like just win on the top, just loss on the bottom. Whereas here, this is the risk. So in a relative risk, it includes everybody who has it out of everybody who is available to have it. And those are kind of the differences in calculating the formula. So for an odds ratio, odds in the exposed group. So basically have it over don't have it in the exposed, and then over have it over don't have it in the unexposed. Whereas relative risk is like, what are my chances of having it in the exposed versus my chance of having it in the unexposed. For relative risk reduction, it's basically a percent change formula. Rate in control minus rate in experimental over rate in the control group. Or like initial value minus new value over initial value times 100. This percent change or percent yield formula that you probably saw all the time in your basic science classes. Or you can see it written as control event rate minus exposure event rate divided by control event rate. This number could come out positive or negative, and basically that tells you if my control rate is higher than my exposure rate, I have a positive risk reduction, then my exposure is helping. If it came out negative, so that means my control rate were lower than my exposure rate, that would mean that it's helping. So that's how they find, for example, that there's a risk reduction in something, or something makes things more common. Absolute risk reduction is just rate and control minus rate and experimental, just a straight subtraction problem. Attributable risk, we need to know our incidence. So incidence exposed divided by incidence non-exposed over incidence exposed. So there we would just use our incidence formula, total new cases divided by total of at risk. We would plug in incidence formula here, incidence formula here, incidence formula here, and solve. Number needed to treat, 1 over absolute risk reduction. So you'd calculate this. So basically, if my risk here is 90% in the control and 20% in the experimental, then I get 70, 1 over 70, or 1 over absolute risk reduction, and then I just calculate that out. My number needed to harm is 1 over attributable risk, and then here we have incidence and prevalence. So here incidence is the new cases over a period of time divided by the people at risk, whereas prevalence is just the total number of cases of people who have it. So incidence and prevalence, something else to be aware of with that. Incidence, it basically matters how many new cases come up, so it doesn't really matter how long you have the disease for. Prevalence, it actually does matter how long you have the disease for, because let's say the incidence is that 6 new people develop this disease a day, and I'm in a population of 100 people. So the incidence is 6 out of 100. The prevalence of the disease lasts 1 day is 6 out of 100 today, 6 out of 100 tomorrow, 6 out of 100 the next day. But if the disease lasts 5 days, then I have the 6 people who got it the first day, the 6 people who got it the second day, the 6 people who got it the third day, the fourth day, and the fifth day, and so on. So now at any given time, I have 30 folks who have it in my population out of 100. So how long something lasts actually does matter for prevalence. So for example, they might ask a question in the exam that says, I develop a new treatment for diabetes. The incidence of diabetes is the same, 10 new cases a year, but the prevalence of diabetes goes up. So on first thought, that kind of sounds like a bad thing, right? Like, more people have diabetes, how is this treatment helpful? But if the incidence stays the same and there are no more new cases coming up, but more people have it, people are surviving longer with it. So that actually could indicate that the treatment is working. So if 10 new cases of brain cancer come up a year and my prevalence is 10 out of 100, then they're only living a year. But if I have 40 people in the population with this brain tumor, but only 10 new ones getting it a year, some of those folks must have been around with that brain tumor for 4 years. So it represents a longer survival. That's a question that commonly tricks people up because it sounds like more prevalence should be worse. But if I develop a treatment that helps people live longer and my incidence is the same, my prevalence should actually go up.
And I'm gonna hop in here for one quick second and say, for anybody that hasn't committed all of those formulas to memory and we're just like, holy crap, that's a lot of information all at once, I promise you it's going to behoove you to just sit down, do it this weekend, do it tonight, whenever you have a free minute, and just start drilling those formulas until you know it cold, because they will be on step 1, level 1, step 2, level 2, and step 3, level 3. They are literally on every single exam. And oftentimes the people that differentiate from that like high 250s range to bumping into the 260/270 range, a lot of the difference is people that know their biostats cold, because nobody wants to spend time on this. It's like the most boring class out of everything. And a lot of the time it's hard to see the long-term impact of memorizing all this stuff. But I promise you, this can be what turns your score into the next quartile. So just take the time. Brianna did a fantastic job of putting out alternate ways that those formulas could be asked and integrated together. So go back to the slides after tonight, review it, because you just have to memorize those. There's no other way around it.